So I don't want to belabor the key findings too much, but there's a few points that are really, really important to keep in mind. The key indicators of the pandemic right now are flattening in some regions, but the impact of the pandemic and the actual direction of these indicators still varies substantially across regions. While it's positive to see that these indicators, like cases, are starting to flatten, it is best described as a fragile or precarious situation where we need to make sure that cases continue to flatten and decline before we can say that we're making strong progress. Long-term care resident mortality continues to increase, although cases are now flattening and starting to decline. ICU occupancy is now over the 150 bed mark that we noted was likely in the last presentation. And under any of the scenarios that we've contemplated, it will be over 200 in December. It's difficult to determine right now, though, whether or not we are seeing a true turnaround in cases. And so keeping in mind that ICU occupancy will only change about 2 weeks or more after that decline in cases, it's too early to say that we're really going to see anything with ICU yet. The access to care overall continues to be below 2019 levels, so the access to care deficit continues to increase. And I think importantly today we'll spend some time talking about how some communities face a much higher burden of the pandemic because of longstanding structural factors that lead to higher exposure to COVID-19. And the importance of this is that public health interventions that we've contemplated so far that by definition affect everyone the same way, they're one-size-fits-all interventions, are unlikely to have the same impact in communities that face a much higher risk of exposure and thus are likely to not be as effective in curtailing the pandemic in those communities and eventually in the province overall. If we could go to the slide that we're up now, thanks, that's great. This slide updates the total new cases per 100,000 residents per week across the public health units. You can see it's going from a 7-day sort of average of about 170s up in Peel down to about 10% of that down in Eastern Ontario. So substantial variation, but I think important to note the variation and the movement up and down over time within virtually every one of the public health units we're looking at, giving this idea that we are not really turned a corner yet. We may see flattening, but really we're in a very fragile or precarious position. If we could go to the next slide, please. This is the new cases with no epidemiological link across public health units. In a situation like this, where we've got very high case counts, we would expect to see a lot of community transmission, which raises those numbers up. But it's a critical measure of public health capacity that hopefully as cases decline, this proportion will improve substantially so that we know the source of cases, and in that period following the second wave, we're able to make sure that we stay on top of outbreaks and make sure that we understand where cases are coming from. And you can see again here, substantial variation ranging from up in the 70s again in Toronto to down under 10 in the lowest public health unit, indicating again this almost 10-fold variation between the lowest and the highest, showing the variation across public health units. If we could go to the next slide, please. This slide shows COVID-19 testing percent positivity across public health units. As we've talked before, we don't rely just on one indicator. We're looking at case numbers. We're trying to look at percent positivity. We're trying to understand that testing volumes stay the same. And when all those move in the same direction, we have a good read on where the pandemic is moving. When they don't, we tend to have some trouble with interpretation. In this case, once again, you see the 10-fold variation between the highest percent positivity, which is over 10% of tests in Peel, down to under 1% in the Eastern Public Health Unit, showing and really reinforcing again the fact that this is not a single pandemic across the province, but really a series of individual micro-pandemics or micro-epidemics that require different approaches in different regions. If we could go to the next one. So this is again now looking at another key measure of our ability to respond to the pandemic. This is the percent of tests processed within 2 days across public health units. I'd want to note again that it's not public health units that process the test necessarily, but you do see variation again in the time that it takes for a test to be returned to people in these public health units. Up over 90% in York, down to almost 1/3 less in Brant, giving you a good idea that there is still, again, variation in what is a key measure of public health system capacity to respond to the pandemic. If we could go to the next slide. So this slide is challenging to read because there's an awful lot of information or data on one slide. This reflects the percent positivity over time by age group. The youngest age groups are at the bottom of this chart. The oldest age groups are at the top of the chart. And as you move from left to right across the chart, you see really that tail end of the, or not the tail end, but the middle of the first wave of the pandemic, with very dark numbers during this time, becoming lighter during the summer as the percent positivity drops really across all age groups, moving on to the fall where we are now, and again this second wave and much darker colors again. What is positive here is that the percent positivity is generally going down across all age groups. And so we find ourselves in this place which is, as we said, sort of a fragile moment where if we're able to continue to decrease case numbers, you'll see improvement in the pandemic, but a small number of outbreaks could dramatically increase case numbers and take us back up onto what looks more like a worst case trajectory. If we could go to the next slide, please. This slide updates the slide we presented last time on mortality and cases in long-term care homes. The green line there is the cumulative deaths. And you'll see that deaths have increased again over the last 7 days by 64. This is lower than what we reported the last time. But as you can see, deaths are continuing to increase. The case numbers are important to look at here because the cases have peaked, it looks like, and starting to come down. That's a positive indicator. And I think reinforces the fact that the age distribution of cases in this second wave is very different from the age distribution of cases in the first wave. In the first wave, we saw a very, very high number of cases in people who were in our oldest age group. We don't see that, or at least it's not the highest spike in this round of the pandemic. As cases come down, you will see lagging indicators like death also start to come down, but that will not show up in a significant way for at least a few weeks, if not more. If we could go to the next slide, please. So this slide updates the first of the modeling slides from the last presentation. I think it's important to kind of note where we were at the last presentation and where we are today. In the last presentation, we were looking at the growth in Ontario compared to other jurisdictions, and looking at a growth rate in Ontario that was somewhere between 3% and 6% over the last few days. Here, we're now in a better position where the growth rate is really between 0 and 1%. Now, this is a challenging situation where we kind of see flat cases to understand where the models are going to go. We've had modeling done at Public Health Ontario as well, and at McMaster University as well, in addition to these models that were done at University Health Network and University of Toronto. And what you see here is a number of different situations that I'll try to make sure are clear. If we continue on the current level of cases, if there is no further growth in the rate of new cases, we'll sort of flatline there, and that might be considered a conservative version of a best case scenario right now. That's that bottom line that says Ontario 1.00. That's reflecting our last 3 days of growth in cases. As we get sort of to higher levels, you can see 1.01. That is the growth if we are a little more like our last week's worth of growth. And then you can see more significant rates of growth at, say, 3%, which was our perhaps baseline scenario in the last briefing, which takes us up above Germany and France in terms of trajectory. And you can see 5%, which is where we were heading at the beginning of the last briefing over the 3 days. Takes us up to an even higher level at a similar time in the pandemic compared to the Netherlands and to Michigan. So what you see here is we're not modeling a decrease in cases right now. It's a little too early to say in this sort of fragile position where the cases will come down, although they're flat right now. And with a sufficient number of outbreaks, you could see much higher rates of growth even than the 1.05% that we've noted here, and as we've seen in some jurisdictions. We could go to the next slide, please. Perfect. So this slide updates the slide on COVID hospitalizations and COVID ICU use. What you can see here is a 63.2% increase. This is slightly up from the 61% that we reported last time. But remember, even with cases flattening, hospitalizations are going to continue to grow for a while because of the progression of the disease and the time it takes to go from infection to symptoms to the requirement of hospitalization. And ICU use will lag even further behind that. So about the same level of growth in hospitalization, but that makes sense even with the recent flattening over the last few days of cases, given the natural history of the disease. If we could go to the next slide, please. And this slide presents the projections on ICU occupancy. Now, of course, the health system is made up of many more components than just intensive care units, and it's important to note that the pandemic affects virtually every aspect of our health system. But you can see under all of our models, we are over 200 cases, or 200 beds in ICUs, intensive care units, in December. And so even with what seems like a flattening now, the progression of the disease through the population and the worsening symptoms in some of the population means that we will see further growth, or we're very likely to see further growth in intensive care unit occupancy under any of the scenarios. I think it's also important to note that under the flat line scenario, which is maybe a conservative definition of a best case scenario right now, occupancy does stay above 200 beds for a fair period of time. And at that level, hospitals are facing significant capacity challenges. They are facing significant threats to the sustainability of their health human resource workforce. And they are making decisions to cancel, postpone, or delay treatments that are necessary. Also, maybe worth noting that the initial modeling or last briefings modeling had said that we would exceed the 150 mark, which is the threshold. We've now exceeded that. Thank you. This slide describes the access to care deficit in the province, and you can see really that blue shape behind the graph, that sort of thing that looks like two peaks. That's the first and the second wave volume of cases right there. And you can see, for instance, in purple, that is the line describing the amount of surgery in 2020 compared to 2019. And you can see in the first wave, there's a dramatic drop in the volume of surgery performed in the province. This creates a deficit in surgery. It reflects people who needed surgery but were unable to likely get it. You can see it coming back up with the different directions to restart surgery and to resume readmissions or returns to long-term care homes. However, it's now back down underneath that red line, which is the line indicating the 2019 numbers. And you can see here the effect of the pandemic continues to decrease access to care. You can see a similar line for diagnostic imaging, which is the beige line. You can see a similar line for virtually any of the types of care that we're tracking here in this chart. I'll just say it is important to interpret the last little period of time in this chart with caution. These numbers do change as they get updated, but it looks with all of them to be continuing well below the line for 2019 volumes. This chart, I think, starts to show some of the important variation in the pandemic and its impact on communities. So for every of the briefings that we've made the point that the impact across public health units is highly variable, that it varies substantially across regions. These maps show you the percent positivity across a smaller unit of geography, across smaller communities. These are what are called forward sortation areas, which are just the first three digits of your postal code. And so we're able to look at the percent positivity on testing across forward sortation areas. And you can see that it is, again, even within public health units, very unevenly distributed. The dark purple indicating places with high percent positivity, and the lighter colors indicating lower percents, and the white where the numbers are essentially low enough not to be calculated. If I showed you the chart for cases, you'd see a similar distribution of cases. Really, if you looked at these charts for almost any of the measures of health or disease status across these areas, they'd look very, very similar. But this gives you an idea that there are communities that are facing and have faced consistently or persistently much higher levels of COVID-19 infection. We go to the next one, please. Now, it's important to understand what is driving this and the time period that this is happening over. So this chart talks about, over on the right-hand side of the page, talks about the level of infection or the cumulative level of cases in different communities across Ontario, again, defined by the information that we have through census and other types of material. And it talks about different communities broken down by whether or not there is suitable housing. And suitable housing means nothing more than there is enough room and enough appropriate room in homes for the number of people living in them. And you can see in that red line, which is the 10% with the lowest level of suitable housing, the level of COVID infection is the highest, and it has been the highest in both the first and the second waves. So it's important to note that this is a consistent phenomenon. Even during our first lockdown, the level of infection was much higher in these communities. And you can contrast this with the second wave, with the lowest line, which is the blue, the medium blue, which is the communities with the highest level of suitable housing. And you can see here again, essentially through the first and second wave, they have had the lowest level of COVID infection. You can see very similar charts if we were to talk about the number of people in essential services, those people who are not able to work from home, who are not able to isolate or shelter in a home during the pandemic. And it's important to note that these are long-standing structural factors here. These are not transient or things specific to the pandemic that drive these much higher rates of infection. This is the last of the charts with data. What you can see, though, is that this creates what we call a prevention gap. Essentially, if the risk of exposure because of housing or because of the nature of employment is much higher in a community, public health interventions that, by definition, in this case, are sort of a one-size-fits-all solution, do not have the same impact across communities. And so whether there's a high rate of exposure and a low rate of exposure in a second community, Community A or Neighborhood A is that with a high rate of exposure to COVID-19, Community B is the community with a low rate of exposure to COVID-19. When the same interventions are applied, they create very different reductions in the level of COVID-19 exposure, very different impact in terms of reduction in the number of cases. This is important because if we take a one-size-fits-all approach with efforts to reduce infection, you'll see this prevention gap open up. In these communities with these long-standing structural factors, infection will remain higher, and actually that will, in the long run, make infection across the province higher as well. So it is not something that can be just isolated within these communities either. Coming to the last slide and just reviewing the key findings. So key indicators are flattening in some regions, particularly those with the highest rates, but the variation in performance against these key indicators across all of the public health units continues, indicating that we are not in a stable or declining situation of the pandemic now. It is still too early to call. Long-term care home resident mortality continues to increase, but cases are declining. ICU occupancy continues to increase. We're over 150 beds now, which was the first threshold at which care is compromised. We're likely to get close to 200 or more in this next month, sometime in December. And that's likely under any of the scenarios, even the best case scenario that we modeled in this briefing. It is difficult, I just want to emphasize, to say whether or not we are seeing a true turnaround in cases. This is a moment of great sort of precariousness where continued sort of adherence to public health measures will hopefully bring case counts down. But outbreaks or challenges in maintaining those public health interventions will actually lead to a growth again in the cases. Access to care continues below 2019 levels. We showed a variety of data for really hospital-based care, but that continues perhaps across a number of different areas of care as well. And some communities do face much higher risk of exposure to COVID-19. This is due to long-standing structural factors that are beyond the control of any of the residents of those communities. And so one-size-fits-all public health interventions are unlikely to have the same impact.